Good morning. Thank you very much for being here, and thank you very much for AIM at Melanoma for organizing the symposium. So after this superb introductory talk by Dr. Ernsthoff, as a dermatologist, I'll actually focus on what we do in dermatology and how we help you with melanoma in dermatology, and that's early disease diagnosis. And during my talk, after discussing sort of some basics of melanoma and introducing melanoma from a tiny bit different angle, I'll focus on subtypes of melanoma. I'll talk about sort of benign pigmented lesions, what we need to differentiate melanomas from, and I'll talk about mostly morphology and how sort of the monsters can be told apart from the moles. And later on, I'll also briefly talk about diagnosis and how dermatology helps you establish diagnosis. Melanoma is one of the most frequently seen skin cancers. And unfortunately, it is also the skin cancer that we lose most patients to. Also, the significance of melanoma comes from the very high increase in incidence that we've seen in melanoma over the past 4 decades. The incidence has approximately tripled. Currently, yearly we diagnose approximately 90,000 people with melanoma. And that has resulted in an increase that created a lifetime risk of approximately 1 to 43 at this point for melanoma. The other thing that we need to recognize about melanoma is, as opposed to many other cancers that predominantly present only in older age groups, melanoma actually fairly frequently affects also younger individuals. And it is the most common cancer currently in women aged 25 to 29, which also shows its significance and really the importance of early diagnosis and for everyone to be aware of melanoma and what we need to look for to catch it. Currently, the number of people living with history of melanoma is over 1,200,000 in the United States. And all of these numbers actually only include invasive melanomas. So they actually exclude the in situ melanomas. With those, actually a lot more people have a history of melanoma. Luckily, most people with melanoma do very well. However, in order to know and in order to help sort of people in general do well with melanoma, we need to recognize that early diagnosis in melanoma is crucial. There are many factors that determine survival, but out of this, the most important factor is how early the disease is caught. To understand melanoma better, I'll go back and we'll repeat some of the things that Dr. Ernsthoff also talked about. Melanoma is a tumor of melanocyte, a cancer of melanocytes. These are the cells that are responsible for creating the baseline pigment of our body, and these are also the cells that then, induced by sunlight, will actually try to mitigate damage to our skin by creating additional pigment. However, when the cells themselves get damaged, they will become cancerous and can become cancerous, and they can show uncontrolled growth. Because of the fact that these are pigment-producing cells, melanoma will often be dark in color, brown-black, and will contain actual pigment. When we talk about melanoma, we often forget that melanoma actually has multiple subtypes. And I think it is important to recognize these subtypes to be able to sort of better look at our own body to recognize potential problem lesions. These are the most important subtypes of melanoma: superficial spreading melanoma, nodular melanoma, acral lentiginous melanoma, and Lentigo maligna melanoma. During the next slides, I'll briefly go through them and we'll highlight some of the important features that these have. Superficial spreading melanoma is the most common type of melanoma. Approximately 70% of melanomas that are diagnosed are superficial spreading. And this is also the melanoma that presents fairly frequently earlier in life, between the ages of 30 and 50. This can arise as a brand new lesion on the skin, or it can also come in a pre-existing mole. When you look at this diagram, you'll show cases of melanoma distributed over the body. I wanted to bring that to you because it's important to recognize that although you'll hear in other talks also that melanoma sort of growth and the induction of melanoma can be driven by sunlight, actually when it comes to superficial spreading melanoma, the most frequently seen subtype, it is not present in the most highly sun-exposed areas of the skin. It actually comes in areas of the skin that are intermittently sun-exposed, that occasionally get burnt, but may not be very heavily damaged by the sun. So in men, very frequently, this is going to be the back. In women, it's going to be the back and frequently also the lower legs. The other reason why I brought this slide is to highlight the fact that melanomas do not only come in areas that are highly sun exposed. Melanomas can actually come in areas that hardly ever see sunlight. And that's also extremely important to recognize when people do self-skin checks. because you have to be aware of your skin kind of all over. In superficial spreading melanoma, what we see is usually you start seeing sort of a dark spot on the skin that will slowly enlarge, will develop areas that lack pigment sometimes, and then eventually later on will actually develop sort of bumpiness within that signals that the melanoma is spreading beyond the top layer of the skin. Catching it early means that we catch it before it spreads deeper in the skin, and that we catch it at a time when it's much less likely to have spread beyond the initial compartment of the tumor, so it's much less likely to actually cause systemic disease. These are some images of superficial spreading melanoma. In superficial spreading melanoma, you'll often see an asymmetric macule or sort of small spot, sometimes a larger patch, that will have border irregularity most of the time, that will show color variegation, multiple different colors within, and which will also often have a larger diameter. Also, these are spots that often will change, and I'll go through this again later on. The next melanoma subtype that we need to talk about is nodular melanoma. Nodular melanoma is the second most common subtype. It's approximately 15 to 30% of the cases. It is more common a tiny bit later in life, and it is more frequently present in highly sun-exposed and sun-burdened areas of the skin. The trunk, head, and neck are most frequently affected. Men are quite a bit more likely to have nodular melanoma than women. Because of its features, because of how fast this melanoma actually spreads deep, this is usually recognized later, and therefore people tend to do a tiny bit worse with this diagnosis. These are a couple of images of nodular melanoma. In nodular melanoma, often you'll see a firm bump on the skin that will enlarge. It can enlarge at times fairly fast, but at times the enlargement can be kind of insidious, and that's the reason why we usually recommend monthly skin checks, so that by too frequent skin checks, you may not even recognize the change in lesions, but with monthly skin checks, it's much easier to catch. And often melanomas will be, nodular melanomas will also be pigmented. Sometimes they can also get ulcerated. They can present in various different areas. Sometimes you can actually see underlying spots or patches that will signal sort of a precursor lesion and potentially a mole that may have prompted the melanoma to start. Occasionally the bumpiness within the melanoma, even in nodular melanomas, is not as evident. And don't forget that sometimes melanomas actually can lack pigment. So not everything that's melanoma will contain pigment, or sometimes, as opposed to the black-brown pigment that you may anticipate, they'll actually show sort of bluish coloration, like in some of these images. The next melanoma subtype we'll talk about is acral lentiginous melanoma. It's luckily less common, but it's still very important to know, because in more pigmented skin subtypes, it is actually the most common type of melanoma. This presents on the palms and soles or around the nail unit, and it most frequently comes about after the 7th decade of life. It is probably driven not as much by sun exposure, but actually trauma to these sites. These are a couple of images, and often it will initially start sort of as a small black-blue area of pigmentation under the nail, or again on the palms and soles, which will slowly enlarge, sometimes can lead to destruction of the nail, or potentially even the nail falling off, occasionally can lead to ulceration and bleeding. Because of the location, because of these not being areas that people are as aware of, this is also often recognized later. So again, one more reason why self-skin check is so important. This is another image of an acral lentiginous melanoma on the sole of the foot. The other melanoma subtype to talk about is Lentigo, Maligna melanoma. This is a melanoma subtype that usually takes a very long time to grow. It grows laterally for a long time before it goes vertically. It often comes in highly sun-damaged areas, somewhat later in life. And because of the slow growth, it although is potentially easier to catch, but it is again one of those subtypes where someone may remember something on their skin that has been there for a long time and hardly changed at all, but that slow growth could still be present. So this is why actually knowing your skin again is important, and potentially even going back to prior photos can be very important to recognizing slow growth in areas of the skin. These are some of the photos. Again, this usually presents in sort of more cosmetically sensitive areas of the skin and presents as sort of variably colored larger patches that sometimes may even have minimal scaling in them, and later on may show areas of bumpiness within or papullarity, like in that photo, that shiny area in the center. Again, as I mentioned multiple times, early diagnosis is key for all melanoma subtypes. We wish diagnosis was, as easy as pointing a dark spot on the skin. Unfortunately, it isn't. The photoshopped images on magazine covers are not correct. Really, our skin actually looks a lot more like this. Our skin normally contains a lot of benign lesions, some which are scaly, brown, yellow, some which are sort of pinkish, brown to black. Occasionally they can be sort of whitish and scaly. Sometimes they will be bluish dark patches that occasionally can even appear black, or sort of cherry red small bumps, or small scar-like bumps on the skin. And all of these are completely benign skin lesions that probably essentially everyone in the audience either has or will have at some point in their life that we need to be able to differentiate melanoma from. There are also other benign spots that are actually made up of melanocytes, made up of the same cells that can give rise to melanoma. And these are some images of these nevi, which I'll talk a tiny bit more in detail during the next slides. Melanocytic nevus, or nevi, or moles as they are commonly referred to, are sort of local proliferations of melanocytes that are considered to be benign, and these are extremely common. They can come sometimes at the time of birth or very shortly after birth, and they can be congenital, sometimes small, sometimes much larger, occasionally even somewhat variably colored, but these congenital nevi are invariably stable in their appearance and should not change. Occasionally they can be acquired during life, and especially early in life, up to the age of 30, 35, they may show some change and may be oval or round, black-brown, sometimes pink in color and soft. Occasionally they can be sort of brown with patch or spot-like areas and central bumpiness to the lesion. Occasionally they may also have two colors in them and not only a single coloration. Sometimes people may have striking features of their nevi, but the interesting thing is that in most of these cases, these sort of almost concerning looking nevi will not be singular, and people will have usually multiple of these on their skin, which can be solid brown, solid pink, can sort of have this eclipse pattern or cockade pattern, or can have a fried egg appearance, or can even have sort of asymmetric, very dark pigmentation in one area. And again, these are all completely benign signature nevi. Occasionally, nevi may also share some features with early melanomas, and we may term them atypical nevi that Dr. Bogner will talk more about. And sometimes these can actually result in sort of diagnostic difficulties for patients and even for occasionally physicians, although there are some features that we can use to differentiate them. And also knowing your skin is very important because atypical nevi are expected to not change or change extremely slowly, if at all, whereas melanoma is expected to change much faster, even if it shares some of the early features. The thing we need to also recognize about nevi is that nevi, again, are benign. And the chance, although nevi can occasionally give rise to melanoma, the chance of nevi giving rise to melanoma is extremely small. So there's no reason to get rid of all the nevi on someone's skin, even with a history of melanoma. We just need to recognize what really are not nevi and what are the bad actors. And how do we recognize these features? There are some features that everyone can look for. The ABCD criteria was originally established in 1985, and since then really has proven the test of time that it helps people recognize melanomas earlier. And not only actually patients, it also helps in the primary care setting for providers who are not as frequently encountering melanomas. E was added to this sort of ABCDE designation in 2004 as also an important feature that can help diagnose problem spots. And what are these ABCDE criteria? You probably are all quite familiar with these, but I still wanted to repeat them. So asymmetry is what A stands for, and that is that one half of the mole looks different than the other half. Border regularity, the border is not nice and smooth, but there are sort of projections from it. Color variability, you'll see multiple colors within the lesion. Often also the differently colored areas are variably shaped and have their own internal sort of border irregularities. Often these lesions will have a larger diameter. They'll be larger than 6 millimeters or the eraser on the end of the pencil. And often they'll show, as I mentioned multiple times during my talk, evolution or sort of constant change. Sometimes that is slower, sometimes faster, but it will be different than change in all your other nevi that occasionally, for example, if someone is exposed to the sun, can also show some very subtle change in, for example, coloration. There's one more feature that I like to highlight to our patients, and that's to look for really something that sort of comes to the end of the ABCD designation as a designation for F, something that's funny or funky, something that stands out of the crowd, something that's sort of the ugly duckling. Because again, people can have sometimes striking appearing nevi, but usually the problem spots will be singular and will look very different than all the other spots on your skin. This is a cartoon that I love that reminds people of sort of what to look for when it comes to really problem spots. And one more thing that I like to highlight, that having had melanoma also puts people at increased risk of other types of skin cancer. Plus, not all melanomas are pigmented. So people, I think, acutely need to be aware of also non-pigmented spots on the skin. These are actually amelanotic melanomas, or one of them has very minimal pigment in it. But you need to also be, again, acutely aware of non-pigmented spots on your skin that could signal non-melanoma skin cancer, but could also at times signal an amelanotic melanoma. So look for growing pink bumps on your skin that often will feel firm, or sores that do not heal. And usually the sort of the cutoff is if something doesn't heal for 4 weeks, it's much more likely to be of concern. If you scratch at an accidental bug bite, it can seem like an unhealing sore, and you may not remember that, for the first week or two, but it's expected to beautifully heal within the first 3-4 weeks. If it's still present, it may be something different, and you may need to pay more attention to it or report it to someone. And also areas of the skin that frequently bleed, even after very limited trauma or after no noticed trauma, are also potentially concerning and could signal both non-melanoma skin cancer or potentially also some subtypes of melanoma. And also, I always highlight spontaneously appearing and growing scars, as that can also be, at times, a sign of skin cancer. We talked about skin check, and Dr. Reed is going to be talking about it more. But I wanted to highlight that self-skin check is extremely important. We usually recommend it at least once a month. For sort of your whole body. Occasionally for certain areas you could do it a tiny bit more frequently, but doing it much more frequently may not be of benefit. And I always also highlight that you should not be doing it alone. All our pamphlets will show you how to do it alone with 2 mirrors in a bathroom. It's extremely hard, and we all recognize that. So try to actually do it with the help of a loved one. It will be much easier, and you'll do a much better job, and set time aside monthly to do this. Because again, early diagnosis is key. And if you notice anything concerning, obviously follow up for a full body skin check, report it to your dermatologist. They'll be able to help you also by looking at the area under a specialized polarized light with dermoscopy that magnifies the lesions. And with the polarized light actually enables us to sort of look through the top of the skin and notice features that would be never noticeable sort of for the naked eye under normal light, and therefore can help us tell sort of the monsters from the mole apart much better. And if we notice something along with you that looks concerning, obviously we need to establish a diagnosis. And diagnosis, although at times, unfortunately, it can also be made clinically, mostly it is made on histology, which Dr. Bogner will talk about during the following presentation. But in order to do that, and in order to be able to under histology diagnose the mole and look at its features to understand the risks involved, we need to remove it. And in order to remove it, we usually will do an excisional biopsy. Sometimes we also do a deep shave biopsy for these areas. Or for very large lesions, occasionally it is permissible to do an incisional or a punch biopsy to sort of identify features and then allow fast treatment. But again, pathology evaluation is key. So to summarize, I went through melanoma and melanoma incidence, and the important thing is to recognize that as opposed to many other cancers that mostly present later in life, melanoma can unfortunately present very early in life as well. Do remember that melanoma originates from pigment cells of the skin, and therefore most of the melanomas will be pigmented, but do not forget that some of them can also lose their color and maybe just pink. Don't forget the different subtypes, and that melanoma can also come in areas of the skin that are not frequently sun exposed or never exposed to the sun. And don't forget the A, B, C, D, E, and add the ugly duckling or the F funny and funky to it, because that will help you, I think, catch disease a lot earlier. And don't forget sort of the importance of following up with a provider if you notice something concerning, because again, early diagnosis is key, and pathology helps us with diagnosis. So with that, I'll yield the podium to Dr. Bogner, who will talk about pathology, diagnosis, and histological features of melanoma. Thank you very much for the attention.